Management of acidity and heartburn during pregnancy involves lifestyle modifications and the use of safe medications based on evidence-based medicine and guidelines like those from ACOG and RCOG. 1. Lifestyle and dietary modifications. First-line approach. Eat smaller, frequent meals. Avoid spicy, fatty, or acidic foods. Stay upright for at least 1 to 2 hours after eating. Avoid eating close to bedtime. Elevate the head of the bed while sleeping. 2. Medications according to guidelines and evidence-based medicine. A. Antacids. First-line pharmacologic option. Antacids neutralize stomach acid by raising gastric pH, providing immediate symptom relief. Examples: calcium carbonate, magnesium hydroxide, or aluminum hydroxide. Calcium-based antacids. Calcium carbonate, like Tums and Calcichew. Calcium carbonate also offers prolonged action compared to other antacids, making it a common choice. Magnesium-based options such as Maalox, Epicogal and Mucogal, which contain magnesium hydroxide and aluminum hydroxide. ACOG and RCOG recommend calcium and magnesium-based antacids as safe first-line treatments for heartburn during pregnancy, supported by evidence-based medicine showing no significant fetal risks or congenital anomalies. Excessive intake of sodium bicarbonate is contraindicated due to risks of fluid retention due to its high sodium content, which may worsen edema and increase the risk of complications like preeclampsia and metabolic alkalosis when absorbed into the bloodstream. Sodium bicarbonate raises blood pH. Formulations of sodium bicarbonate like fawurfruits and stomagas. Considerations: avoid excessive intake of sodium bicarbonate. Drug interactions. Antacids can reduce the absorption of iron supplements, which are often prescribed during pregnancy. To avoid interactions, separate dosing by at least 2 hours. Combination antacids. Products containing magnesium trisilicate should be avoided due to potential fetal risks. B. H2 receptor antagonists if antacids are insufficient. Examples: ranitidine or famotidine. Famotidine like Rani-F. ACOG and RCOG consider H2 blockers like ranitidine or famotidine safe for short-term use in pregnancy, with ACOG confirming no fetal harm at standard doses and RCOG recommending monitoring for long-term use due to its effect on nutrient malabsorption, vitamin B12 and calcium, or kidney dysfunction. Evidence-based medicine. Ranitidine and famotidine are FDA Category B drugs, showing no risk to the fetus in animal studies, though there are no well-controlled studies in pregnant women. Evidence suggests they don't increase the risk of teratogenic effects or preterm birth. A systematic review confirms their safety and effectiveness in managing acid-related disorders during pregnancy, with famotidine being preferred due to lower systemic absorption. Dose adjustment. Famotidine is usually prescribed at 20 mg twice daily for pregnant women, but the exact dosage should be tailored to the patient's needs. Ranitidine was withdrawn from the market due to NDMA and nitrosodomethylamine contamination concerns, while famotidine has not faced similar issues. C. Proton pump inhibitors for severe or refractory symptoms. Examples: omeprazole, lansoprazole, pantoprazole or esomeprazole. Omeprazole and lansoprazole are commonly used due to their established safety profile. Omeprazole-like Pepzole, Omas, Napazole, lansoprazole-like Lantanin, Lanzofudil. Pantoprazole is not specifically highlighted in ACOG or RCOG guidelines. Pantoprazole-like Pantoloc, Pantazole and Contraloc. Esomeprazole is also considered safe but should be prescribed with caution. Esomeprazole like Nexium and Esomium. ACOG and RCOG consider proton pump inhibitors safe during pregnancy for severe symptoms like GERD or peptic ulcers, especially when antacids and H2 blockers are ineffective. They stress that proton pump inhibitors should be used only when the benefits outweigh potential risks. Evidence-based medicine. Most proton pump inhibitors, like omeprazole and lansoprazole and esomeprazole, are FDA Category C, meaning animal studies show no risk, but human data are limited. There are fewer studies specifically evaluating esomeprazole safety in pregnancy compared to older PPIs like omeprazole and pantoprazole, so it should be prescribed with caution. Pantoprazole is classified as FDA Category B, indicating that animal studies have shown no fetal risk, and limited human data suggest it is safe. Pantoprazole has minimal placental transfer compared to some other proton pump inhibitors, which may make it a safer choice in certain cases. D. Alginates for acid suppression and symptom relief. Action. Alginates form a viscous gel-like raft that floats on the stomach's gastric contents, creating a physical barrier. This barrier prevents gastric acid reflux into the esophagus, thereby reducing symptoms like heartburn and GERD without systemic absorption. Example: Gaviscon contains sodium alginate combined with antacids like calcium carbonate or sodium bicarbonate. Peptac, similar to Gaviscon. Algicon, sodium alginate with magnesium hydroxide. Topalcon, alginate with aluminum hydroxide and magnesium carbonate. Guidelines. ACOG/RCOG. Alginates are safe, effective, and first line for mild to moderate GERD in pregnancy due to their non-systemic nature. NICE. Preferred over systemic medications for mild symptoms and as adjunct therapy for severe GERD. Safety profile. Highly safe. Non-absorbed, posing no fetal risk. Side effects. Rarely cause bloating or constipation. In Gaviscon, the sodium bicarbonate content is typically low and considered safe for managing GERD symptoms in pregnancy. However, caution is advised for women with conditions requiring sodium restriction. Medications to avoid. NSAIDs can worsen symptoms and are not recommended during pregnancy. Excessive intake of sodium bicarbonate containing antacids, risk of fluid retention. Magnesium trisilicate, potential fetal risks. This approach aligns with the principles of evidence-based medicine and ensures both maternal comfort and fetal safety.